Good morning, good evening, good afternoon, uh, yeah, friends, collaborators, partners, whoever has taken the time to join us here today for what is episode number 2 of the Unboxing AI webinar by CARPL.ai. Today, we are joined by somebody I have the privilege of calling a close friend, Dr. Krithika Rangarajan. Uh, Kritika, if you don't mind, could you turn on your camera? Yes. Uh, so, so we do this webinar. We went through a bit of a thought exercise. Should we do a podcast, which is asynchronous, or should we do a webinar where there are people joining in real time, asking questions? And, we came to the conclusion that just the stature of people that we have, there might be folks out there who want to ask questions. So why deplete them of that opportunity? Before we jump into the actual webinar, quick shameless plug about CARPL. We are an enterprise imaging AI platform. Um, what is an enterprise imaging AI platform? Well, we allow healthcare providers to access the entire ecosystem of AI applications. Today, we have more than 110 from 50 different vendors. So a healthcare provider can access, assess, and then integrate all of these AI solutions into their workflows using our single user interface, single data channel, and then also a single procurement channel. But yes, getting to Kritika, I am going to do a fairly embarrassing introduction for you, Kritika. I am warning you in advance. So for those of you who don't know Kritika, she is one of those people who you always look up to in life as somebody who has just the breadth of experience and depth of knowledge in subjects that one aspires to to have breadth and depth in. So Kritika was with me in high school, and that's why I take certain liberties with her. But Kritika is a radiologist trained at India's Apex Institute, the All India Institute of Medical Sciences, which is where she practices today as an oncoradiologist. Also runs an AI lab there. I think it is possibly the first of its kind in the country, in a government institution at least. And she has also done a PhD in computer science from the Indian Institute of Technology, which is mind-blowing to say the least. And yes, she's also a CARPL power user, of course. So Kritika, we typically start these sessions with a very simple yet sometimes complex question. How would you describe what you do to a 5-year-old? Right? What is it that you do both on the radiology and the AI side? I've had to add that caveat for a lot of people now. So yeah, and I'm sure you have experience of doing it to your own 5-year-old, but yes, how would you do that to a 5-year-old?
Yeah, so first of all, Vidur and the whole CARPL team, really thanks for having me here. I think you guys are doing a fantastic job. I mean, before we started off with this, I was talking about how I like listening to the NEJM AI podcasts. And I would imagine, your own webinar series getting up there and, people wanting to sort of hear you guys. So fantastic job. And thanks for warning me on how embarrassing the introduction is going to be. I think you hit the nail on the head. It was fairly embarrassing. So, but yeah, I'll move on to the question you began with. So, and again, thanks for putting it out there that it's for a 5-year-old, because I'm literally thinking of how I would explain it to my 5-year-old. So like you said, I'm both on the radiology front. I'm a practicing radiologist. I focus on oncoradiology. So I do only cancer imaging, and I have a specific focus on the breast and head and neck cancers. So we do both diagnostic as well as interventions related to particularly the breast.
No 5-year-old will understand that.
Yeah, yeah, I know. It's taken some training for my 5-year-old to start understanding these terms, but trust me, they start understanding. But yeah, so overall, it's cancer patients we try to diagnose with imaging. It's about interpreting what the image is showing them, and largely around, okay, is your cancer becoming worse? Is it becoming better? Is it, how is it responding to therapy? And sometimes we kind of try and go in. So instead of opening the patient and doing a full open surgery where the patient needs to be under anesthesia, often we try to localize a lesion on some imaging modality like the CT or ultrasound or mammography. And then we get in with a needle and try to ablate the tumor, that is, burn the tumor and come out. Or sometimes, I mean, most often just take a little part of it and come out so that we can analyze the tumor. So that's the clinical bit of it. And as far as the AI is concerned, we're basically, we have a huge India focus here, and we're trying to look at how AI can really help us navigate some of the healthcare problems that we face in India today. And this is largely around, the shortage of manpower. And India is in a very unique position in the sense of, while a lot of the world is looking at how do you improve accuracy, we are really looking at how do we get down to, interiors of villages which just don't have access to imaging, where you just don't have access to radiologists. In fact, to doctors, forget about radiologists. So we're really looking at, given that if you have 20 radiologists today, how can you get to doing maybe 2,000 imaging scans with these 20 radiologists and still get the same sort of output out of them?
Interesting. So, Kritika, you're somebody who studies like both the global AI landscape, and I'm sure you're, constantly thinking about how to apply some of those maybe algorithms that are made for the not developing world into practices here, or into like your practice here. So is there anything like unique that you've seen there, that either works or does not work? Because we have a lot of AI developers also listening in today. So any kind of guidance that you would get, or do you think that there is a lot of transferability in what is built, say, for the US or for Europe here, especially from maybe a mammo standpoint?
Yes, I think that's a very good question there. So I would say it's a yes and a no, in the sense that, is there transferability? I think there is a fair amount of transferability. The biology is essentially the same. So it isn't true that you cannot use. So this is for people who start off with projects which are largely around. I say this largely in academic settings, that most often when you're starting off with a project, there is a tendency to think of it as, this was done in the US. Let's try and reinvent the wheel and do this again for India. So that's where I think that it's not really necessary to really do all parts of it and repeat it just because it's not a different thing, just because you're doing it in India. But it's very important to catch the nuances of it. I mean, there is a data set bias, because our data sets look fairly different from what the West looks at. And since you mentioned mammography, I mean, I think it's a very good example to give to explain this, because while the West and most developed countries, so to say, do implement a population level screening program, where the incidence of cancer is probably going to be something like 8 or 10 in maybe 10,000 studies. India, we see our data sets see nearly 20% of them have cancers. So that's 20 on 100 versus say 10 in 10,000. So there's a huge difference in the kind of data set, the distribution of the data sets, in terms of where you're expected to find the positive findings. But there's also a very interesting other connotation to this, which is that when we began with the mammo and we sort of just started sort of putting in the trained algorithms into our data, and we start seeing what was happening, we found that interestingly, some very obvious, staring back at you kind of cancers being missed completely by AI. And the reason for that is, their data sets just did not have such big cancers. So the network's really never seen something as big as that. So these are two, probably very obvious kind of differences which anybody who's starting off with the field will see. But I think there are more subtle and more nuanced differences as well, which is, for example, again, in case of mammo, we see cancer in India a whole decade before the West sees it. So if the peak of cancer in the West is somewhere around 55 years of age, the peak of cancer in India is 40 to 45 years of age, when the breasts tend to be a lot denser to mammography than the West sees. So we have an additional problem to cross in terms of building algorithms which can see cancers in denser breasts. So these kind of very nuanced differences come about only when you closely work with a team of radiologists or practicing physicians who practice in India and are familiar with the landscape over here.
So that's
So I
very interesting.
think
Yeah.
a very I mean,
No, I was going to ask, and before I ask, so for everybody who's attending, please feel free to use the chat or the Q&A to ask any questions that might come to mind, technical, non-technical, whatever it is, just shout out. In case we are unable to cover it in the balance time, we'll post them on our LinkedIn community and answer there. But so Kritika, tell me one thing, how does an AI developer then fix this? Because two ideas kind of come to mind, right? One is the obviously large lesions. Is there a way then one can maybe combine a clinical breast examination with a mammo AI solution and kind of, boost the, uh, sensitivity, if I was to say, because it's strange, right? It's missing large lesions. But do you think something like that, like almost a clinico-radiological AI approach, or is it simply about just having those cancers in the training data set and having a new version of the algorithm? Because from an AI developer standpoint, to maintain multiple versions of the same algorithm, both from a DevOps and a regulatory perspective, becomes very difficult, right? So any guidance you would have there?
so I think first up, you need to have all kind of data. So there's no two ways about it. If you're intending it to be in a developing country setting, you do need to sort of include data from everywhere. So the size is one thing that we see, but there might be a lot of other subtle things that we really don't see. So there has to be a diversity of data sets, and it should include data sets, for the places where you seek to deploy them, to catch the entire variety of the spectrum of changes. The second that so for example, we have included clinical history, so that and that's I feel that that's something that we're not doing very often, not often enough in radiology. Uh, one of the basic dictums you teach a resident when they're training in radiology is ask for the clinical findings. You can't try to treat the image, so you can't try to just interpret an image. You need to correlate with what the patient is feeling, or you're not going to do a good job at the diagnosis. So it's very similar for an AI algorithm. So you don't want to be missing the palpable cancer. So it's absolutely imperative that you include this history into your network itself. And we've seen that one of our best networks, best performing networks, is the one that takes the clinical history into account. As far as CBE, the clinical breast examination is concerned, it also comes with the problem of employing additional manpower to do the clinical breast examination, so which at an implementation level may not really be possible.
No, pretty interesting. So you already have a model where the input includes the image and clinical history. That is pretty cool. Yeah, we
Right.
should check that out. So we're getting in a barrage of questions. Maybe we could take a couple of them. One very targeted, one that everybody should know. What age should a GP ask for a mammogram from a lady?
So India doesn't have a very good policy for asking for mammography, and one of the reasons is the dense breast that I was just talking about. So the Indian breasts and Asian breasts in general are denser to mammography than the Western breasts. So the sensitivity of mammography as an investigation is actually lower than it is in the West. Having said that, if one can afford a mammography, then probably good to get it done, at least once at about 45 years of age. But can this go into a national program as a recommendation? I don't think so. I don't think we have enough evidence yet. But
And
at a
then there's a
personal level,
related. So what you're suggesting is if you can afford it, then once a year post 45, ideally, and okay, that's pretty cool. There's a related question that you're mentioning history for screening mammos. Aren't most of these just supposed to be negative if it's truly a screening mammo?
yeah, correct. So so that's the reason why most international algorithms don't actually even elicit a history. But in India, we have a very special situation because we do diagnostic mammography. We hardly ever do screening mammography. In fact, in AIMS, we do opportunistic screening. So, for instance, if there's a patient who's come in for a different complaint, typically a different malignancy, like an ovarian malignancy, which puts you at higher risk of breast, then we do a screening. Then we do a mammography. We offer her a mammography. But I think it is still a good idea to ask for a history. So wherever it is collected, it's always a
And
good
maybe
idea.
family history as well, right? Family history can
Yeah.
also play a role, at least in maybe starting screening earlier. I don't know. What's your opinion on ultrasound screening starting 35 in women with family
Yeah,
history of
absolutely. So
breast cancer?
so ultrasound is an excellent modality, but then again, it needs to be performed by a radiologist. So again, on a public health sort of setting, it's again very difficult to implement it. Um, yeah. So one, since you spoke about the family history, another example of how AI can help is what we started doing is we've also started looking into the risk factors. So this is another project which is led by a colleague of mine, Dr. Jitendra. So what we do know is that the incidence of breast cancer is very low in villages and very high in cities. And we also know that there's an increasing incidence of breast cancer, and nobody knows why. So the idea behind this was that, if there are protective factors, we need to identify them and stop them before our incidence of breast cancer becomes as high as it does in the West.
Hmm.
So
Interesting.
these, very details who have cancer, and then ask patients who don't have cancer. And we do this separately for a rural setting and separately for an urban setting. And we're using machine learning to really sort of just find the differences in these data sets. So it's like multi-dimensional data. We have a lot of parameters that we're looking at, including stuff like, the food they eat and whether they use deodorants and, all the anecdotal kind of things which are believed to lead to cancer. And we're looking at how machine learning can actually give us insights into what's happening there.
Very cool, yeah. I had no clue. And are there any hypotheses that are emerging, or is it too early?
So I think it's too early. We do have a lot of data, but then it's not very concordant yet. So I think, as you would imagine, you need a lot of data for something so exploratory. And then there'll
Yeah,
be
and
the
then there's
associations, whether they're
and
causative
then
or not.
there's
So
a very relevant question by Ajay that is it simply because we are not detecting cases in rural India that the incidence maybe falsely seems to be low, or is it like truly low?
yeah, so I think that's a very good question. But no, so these low figures are even in very good registries like Bercy, for example,
Hmm.
has very detailed information. This is not a data gap. There's definitely more than a data gap. It's not really only because of the data gap. Some of our villages um, are very well provided by healthcare as well. So not all of them are have these very large data gaps.
Nice, amazing. And on that point, there's another very interesting point here on data, that what's the research methodology, or maybe say rules for data collection, especially in cancer in India? Like, are there any guidelines, or how does it work?
So for the AI bit, it's very important to uh, train your algorithm with, so because it's going to magnify that bias. So we at least follow a very, very stringent way of sort of benchmarking our training data. So we look at biopsies, and if you don't have biopsies, this is an exclusion criteria. So it's a good idea to look at the particular clinical problem that you're facing and benchmark. So you decide your rules before you start the study and ensure that it's concordant to get to the real truth. I don't think there is a nationwide guideline on how the data should be benchmarked. If I assume this is your question, is it on the benchmarking of data, or is it really on the
Yeah,
data?
I think it's on the method for data collection. So I guess it's just hard work. Probably is the underlying answer.
So
But
method,
there's
how do you
a
track?
flow of questions.
Okay,
Sorry,
here you
I'm
go for it.
clueless on how to do this. There's one relatively controversial yet high potential technology out there is thermography, right? The question goes, does thermography have a role as a screening modality for cancer in India? And is it different from that seen in the West? You have any
So
opinions on that?
So I mean, I think it's a bit of a controversial question, and I'm only giving my personal opinion on it. So firstly, thermography as a modality requires the woman to sit inside a cold room. So you're going to undress the woman, make her sit inside a cold room, and then wait for about 15 minutes for the imaging to really happen. So I think even just in the method of acquisition, I don't see it making it to being a nationwide sort of screening tool. Simply because it's inconvenient. How do you maintain these, cold chambers all around the country? India is a hot country. So, and is that investment really worth it? Because if you really come to think of it, I don't think we have large scale studies on the sensitivity and specificity of thermography and adequately validated against, a gold standard. So, if I had to put my money, let's put it this way, I wouldn't put it on thermography.
Okay. No, thank you for that candid, and non-political answer. Uh, this is by, this is a question by a radiologist, Salil. He asks, can one algorithm learn from or talk to another algorithm?
Yeah. So hi, Salil, and yes. So basically, so there are different ways in which you can combine the output of an algorithm. And often, when you actually deploy, you don't deploy a single algorithm. You typically deploy what's called an ensemble or an ensemble of an algorithm. So what that essentially means is you're going to sort of combine two or three algorithms, and you've seen that when you combine multiple algorithms, it tends to perform better. The combination of them performs better than a single one. Also, there are other ways of combining the output. Sometimes the output of one algorithm is fed in as the input of another algorithm, and that also is another pathway for improving the performance of the algorithm.
On that note, I am going to ask one question. Have you played around with or have you dug deep into foundational models? And yes, as Dr. Avnish Khare also has mentioned, transfer learning. Have you like what is a foundational model? What is transfer learning? These terms just get thrown around. So since there's a lot of radiologists here, could you explain?
Yeah. So I'll take the transfer learning first. It's the easier question, and I think pretty well validated now. So transfer learning essentially means that you're going to start the training of your algorithm with some features that it's already learned. The easiest way of explaining this is, supposing there is an algorithm which has already seen enough natural images. So it's seen what a cat looks like, what a dog looks like, what the sky looks like, what clouds look like. A lot of these features kind of help it understand, features that you would see in medical images as well, because it understands what lines are, what boundaries are, and things like that. So what you would do is you would start training your algorithm rates, getting a little technical, but you would start the, you call it initialization. So when you start training the algorithm, you would start with whatever it's learned in the natural images. And this would get accentuated when you go into medical images, in the sense that, let's say you want to train an algorithm for Indian data, and you already have an algorithm which is trained on Western data for the same problem. Then what you would do is you will try to sort of pick up. You start the training of the algorithm from the point where it's already learned the features in the international data. So you've seen that, and there are no two ways about this. Definitely, algorithms perform better when you use transfer learning in comparison to training from scratch. And often it also is true because the data set you begin with are typically much larger. So natural image data sets would be in lakhs, whereas medical imaging data sets are typically in thousands. So it helps for it to have seen many, many more images of a particular kind before it starts learning. So transfer imaging is definitely, is something that you can use. Foundational models, we've been looking at particularly the foundational models that Google's come out with for chest X-ray. So recently, that made big news that Google has sort of released their foundational model for the chest X-ray for research purposes. But we haven't actually used it. So what is a foundational model? It's again, a model which has been trained on lakhs and lakhs of data. So it kind of, so it's been trained in, it's not going to really give you a yes no answer. It's not been trained for a particular purpose. It's going to give you something that's called a feature vector at the end of it, which is just its understanding of the features within a particular model. So for example, the chest X-ray model basically understands what a chest X-ray looks like. So it knows
Hmm.
all the features of a chest X-ray, and therefore, if you train your model over this foundational model, you would get a kind of safety margin. So if, even if you're training with a smaller data set over this, you know that it has at least learned a certain set of features. So that's the idea of
Got it.
foundational.
So it's like a silly analogy would be it's like having a 12th pass person as opposed and then teaching that person something as opposed to maybe trying to teach somebody from grade 1 all the way. So you don't need to go through the pain of taking somebody from grade 1 to 12 and you directly get a 12th grader. Last 2 minutes, there are questions here that we will certainly answer in our on our community page, on the LinkedIn page. I do want you to share your thoughts on closing thoughts on if there is a relatively young person, we all think we are young, but say younger than us, person out there, one thinking about whether to build a career in imaging AI, informatics, our world, should they and what should they do towards that end? Right, whether they're a clinical person or a technological person or just a commercial person, what would be your guidance?
Yeah, I think so I think the first part is something that we all get asked a lot, right? So and particularly this is, students come up and say that, look, I'm really interested in radiology, but I'm not sure if I should pick it up because I'm not sure if radiologists will exist maybe 10 years down the line. So to them, please do. I mean, I think radiology has kind of always been at the forefront of change, and I think that's what makes it exciting as well. And certainly, while you might think that the workload is going to decrease dramatically because of AI, it's going to take up a lot of work. There is an assumption you're making there, which is that you're assuming that radiology 10 years later is going to look the same as radiology does today, which is not true at all. It's going to be dynamic. It's just going to look very different from what we do today, but it's always going to remain, at the cutting edge of change. So for people over there, I think definitely do go ahead and take up radiology. For everyone who is within radiology or anywhere in medicine, who want to sort of who are thinking of going ahead and doing AI. So yeah, I mean, certainly AI is the way the future is going. I mean, it's touching all aspects of life, and medicine is no different. It's definitely going to transform the way you practice medicine. There is little doubt about that. Um, and I think the important thing that you need to ask yourself is what aspect of AI do you want to sort of be in? Do you want to sort of be in the development? Do you want to sort of be the one who's envisioning change? Do you want to be the one who wants to just use AI and you want to understand how to use AI? And once you've been clear on this, then essentially I would say that the best way to start is to start off with being in projects which actually do this. Because till the time you actually dirty your hands, you won't really get a good feel of what you're up for. And so anyone in practice or in training, find an opportunity around you to engage in a project. There will be a lot of work that you might not like to do. And I'm talking about annotation work. That's typically the first thing that's handed out to doctors. But in the process of being in that group, in the process of attending those lab meetings or understanding how the network works, it's between all of this that all the learning happens. And, that's how you explore the field. Perhaps I'll just look at some of the questions.
Yes,
Oh, no.
I think back.
Okay, great. Yeah, I was just looking at some
Sorry
of the
about
questions
that.
over there.
Yeah. No, I guess, Kritika, I think in the interest of time, maybe we'll answer these offline.
Yeah,
We
sounds
try to stick to time so that people can plan stuff accordingly and all that,
good.
as much as we want to reply to some of these. But yes, please do join our community. You will have all the answers there. Kritika is a very approachable person. Just find her on LinkedIn, Twitter, reach out to her. I'm sure she's more than happy to answer everything. But no, Kritika, thank you so much for joining, and thank you so much for bearing with these internet issues. And thank you to all the attendees, as Zoom calls it. And yes, hope to see you here next week. Next week, we are going to be having Dr. Osvaldo from FIDI in Brazil. So very different profile, very different person, very similar questions. So thank you so much to everyone, and thanks, Kritika, once again. Yeah, means a lot.
Thanks, Vidur. Thanks for having me, and thanks to everyone who joined. Thank you. Bye.
Thank you. Bye.